Hi, good evening to all of you. And my case is a 68 years old gentleman, a known case of diabetes hypertension, presented to us with anterior MI Jan this year with COVID. We took him for primary angioplasty, and this was the angiogram. Proximal LAD had significant calcification, had was thrombotic occlusion, 100% occlusion. The disease was extending into left main as well, and the right coronary artery also shows there was a significant disease in the proximal RCA with significant calcification. So during the index procedure, we went ahead as the disease was extending into left main. We did mini crush angioplasty, left main to circ, left main to LAD under Ivus guidance. The procedure went off well. Patient was discharged. Patient came back after 6 months for planned procedure for the right coronary artery. Sorry. We already knew the anatomy. We knew there was the RC was heavily calcific. We had our plans ready, but during the LAD angioplasty, we didn't have to do much debulking at that point of time. We thought we might as well probably get away with just NC high pressure balloon dilatation. But we didn't want to underestimate calcium, so we wanted to go ahead with intravascular imaging. We wanted to use OCT, but that time our OCT machine had some problems, so we were forced to use Ivus. Ivus catheter couldn't go beyond the first RCA disease. So we did pre-dilatation. It was a big artery. It was almost like 4O artery. So we straight away went ahead with 3.5. It did not yield. The lesion did not yield. We went ahead with 412. Again, you can see a dog boning, a critical proximal RCA not giving way with even 412 NC balloon at high pressure. So this was the angio after doing balloon dilatation. It had hardly done anything to RCA. And here we had two options. One, to use IVL. Now we already made passage in the proximal RC, or to use a rotational atherectomy. But we have been using Rota very regularly, so we went ahead with rotational atherectomy first. We thought probably we can make good passage and then put a stent there. So it was a large artery, so we started with 1.75 burr, did rotational atherectomy in the proximal to mid RCA. And as usual practice, post-rotation, this is the Ivus run after post-rota, which showed there were few cracks in the calcium, but we were not happy with the lesion preparation. The lumen area was hardly 1.85, and it did not really significantly did anything to the calcium. So we thought probably we could use cutting balloon, as most of the time post rota we do use cutting balloon. So the available cutting balloon on the shelf was 3.512 Wolvorine. We did that, but it also had a significant waste. So the issues, or the what were going on in the mind, whether to upsize the burr to 2 or 2.25, or to use IVL at this point of time. But then we thought, we have done enough to the calcium, let's go ahead and do IVL, because probably it's a big artery. So we went ahead with 4O12 IVL, and you can really see how the IVL opens up. The lesion has given way with IVL with the first cycle of the pulsations only. So we delivered all 8 cycles all across proximal to mid RCA. The lesion opened up quite well. So this is post IVL 412. And again, we didn't want to underestimate calcium again. And then, as we have seen already in the earlier case, we have done IVL. We say we have done enough. We probably go ahead and put in a stent. But sometimes, in other view, the stent has not opened up. So we didn't want to take a chance. We did pre-dilatation again with 412 balloon. We made sure that the balloon has uniformly expanded. Did Ivus run. For the lack of time, I'll just run through. We could see a good cracks in the calcium in the proximal RCA. Post that, we could pass on 448 everolimus eluting stent, and the usual procedure, post dilatation with 412 balloon, and this was the final picture with Ivus. So we had a good expansion and 11.97 MLA. So it was a good expanded stent for 48 everolimus eluting stent. So the take-home message that complexity of calcific coronary disease treated with PCI increases. The use of adjunctive devices to ensure optimal stent implantation is the key for improvement in the both short-term and long-term outcome in these patients. Effective techniques available like IVL balloon, scoring balloon, cutting balloon, or high-pressure NC balloons, or atherectomy, rotational, or orbital atherectomy is not available with us, but should be used adequately whenever needed. And usage of intravascular imaging is very helpful in most of these cases. Thank you.